بسم الله الرحمن الرحيم. احنا هنتكلم النهارده عن المyometrial masses. Mainly المyometrial masses will be imaging of fibroids and to lesser degree another entities. The lecture will be part 1 and part 2, and part 1 mainly on the fibroids. The fibroids are very common in women in the childbearing age group. They can occur in 2 or 3 out of every 10 women over the age of 35. It is common to have more than one fibroid. Some women may have as many as 100. Fibroids occur most often in women between 30 and 50, but nowadays we can see in their 20s women having fibroids. 3 out of every hysterectomies are performed because of fibroids. These figures show the different appearance and the different locations of fibroids. This is the intramural, the submucous, and the subserosal, and this is another entity, the intracavitary, the pedunculated subserous fibroid. This is the different appearance of fibroid, and then we will come to the FIGO classification of leiomyoma. الفيجو leiomyoma subclassification اللي هو International Federation of Gynecology and Obstetrics. We will classify the fibroids starting from 0, the intracavitary fibroid, to 7, which is the pedunculated subserous fibroid, and in between we have different categories. So mainly the 3 concerning us here is those indenting the cavity that cause infertility in most cases, bleeding. Here this is the intracavitary fibroid, and then the submucous fibroid, and number 2, here more than 50% submucous, and less than 50% submucous, and here we can term it intramural. Then we have FIGO 3, just contact the endometrium, يعني 100% intramural, 4 intramural, 5 intramural reaching subserous, 6 subserous, 7 pedunculated subserosal fibroid. We have كمان other entities not seen here, other cervical and parasitic fibroid. Cervical fibroid is not in the classification, but we can find cervical fibroid, and then other parasitic fibroid that implant on the peritoneal cavity. Mostly it may be pedunculated subserous and detach it from the uterus and become parasitic on the peritoneum. So we termed it parasitic fibroid. And here is the hysteroscopic classification for fibroids of the submucous fibroid. This classification states that 0 fibroid, nearly similar to the FIGO classification, 0 fibroids totally within the cavity, 1 more than 50% in the cavity, or 2 less than 50% in the cavity. There is another classification of fibroid necessitating intervention. In stage 0, if the size less than 2 centimeters, if the topography is low, if the extension of the base less than 1/3 for this fibroid, 0 penetration in the wall, so this is stage 0. دي تفصيل يعني this is more specification of the criteria of the fibroids. Stage 1, from 2 to 5 centimeters in the middle of the uterus, attachment to the base of the uterus from 1/3 to 2/3, and less than 50% penetration in the uterine wall. FIGO 2, more than 5 centimeters in the upper part of the uterus, more than 2/3 extension in the cavity, and more than 50% within the intramural, more than 50% intramural. And this is the scoring according to the hysteroscopic myomectomy. According this grade, we can, is it difficult for hysteroscopic myomectomy or not? Then we came to the imaging of leiomyoma and their variants. What is the role of imaging of leiomyoma? It allows classification by location in the uterus and the pre-treatment planning. يبقى الimaging, the main role is the pre-treatment planning. Still, ultrasound will be the first imaging modality of choice because it is a cost-effective, portable, real-time examination that provides good anatomical details without radiation. Then came the MRI. MRI, however, is the most accurate and desirable tool for pre-treatment planning. An appropriate pelvic MRI protocol should include multiplanar T2 weighted sequence as well as T1 weighted sequence before and after administration of contrast. And then came the utility of the fusion weighted image, which is still of query rule. Is it important to differentiate between benign and malignant entity? We will see later on in the lecture. Although CT is not a recommended modality, not contraindicated as some say, it is not a recommended imaging modality for evaluation of leiomyomas. They are frequently incidentally seen, usually appearing as variably enhancing mass, sometimes with dystrophic calcification. Here is a female with dysfunctional uterine bleeding. What is this? This is the uterus by transvaginal ultrasound. And there is an intracavitary mass. This is a totally intracavitary mass. It is isoechoic to the myometrium, showing high vascularity but not vascular pedicle sign. It is a perifibroid plexus of vessels. And this mass is also protruding through the cervix. So this is an intracavitary mass, but from the ultrasound criteria, it is fibroid, not polyp. Here, this is the intracavitary mass protruding outside the cervix, showing the whorly appearance. And here is the role of 3D and 4D ultrasound, where we can see the fibroids in the wall of the uterus. Here, it is not indenting the cavity at all. This is the multiplanar 3D reconstruction, and this is the surface rendering mode. Here is also the surface rendering mode, showing the endometrium and showing the fibroids just indenting the cavity. So this is FIGO type 3. This is FIGO type 3. Here is a subserous myoma. Most fibroids are isoechoic to the myometrium on ultrasound. Most fibroids isoechoic to the myometrium. When you find a subserous fibroid, you can also measure the attachment with the uterus. Here the fibroid attached by a large size to the posterior uterine wall, which is difficult in removal. In contrast to the pedunculated subserous fibroid, where we can find just a pedicle. This is a pedunculated myoma. This is the pedicle here. When you find a pedicle, you can measure the length of the pedicle and the thickness of this pedicle, and you see if this fibroid is good vascularized or not, because sometimes it is liable to torsion and degeneration. Here is another fibroid, but this fibroid is so innocent fibroid. It is stage 4 FIGO classification. It is totally intramural, not indenting the cavity. It will cause no trouble. I think no mass effect it will do, no bleeding, and so it is an innocent fibroid. Just state that it is totally interstitial fibroid, not indenting the cavity. This is another fibroid, but here the 2D ultrasound is deceiving, because if we see that plane, you can say that it is intracavitary with the endometrium stretched over it, and it's not the case. When we do 3D ultrasound, you find here this is the endometrium indented by the fibroid, but here the fibroid less than 50% protrudes inside the cavity. This is another myoma, but here it is submucous in location, and here by the 4D you find it is submucous in location. This is stage 1. Stage 1 FIGO classification. This is also a small fibroid, but it is not a polyp. Being isoechoic to the myometrium, there is a myometrial base in part, and there is perifibroid venous plexus seen. This is another myoma, but this is intracavitary. Again, the fibroid is isoechoic to the myometrium. There is myometrial base here. By 4D you can find also the myometrial base, so this is fibroid and not polyp. And this is the perifibroid venous plexus, no evidence of vascular pedicle signs seen in endometrial polyps. interstitial fibroid also, vascular on color Doppler. Please, when you find the myoma vascular, not necessarily being so vascular that it is malignant. It may be just normal vascularity, peripheral, maintaining a benign character with normal arborization, so this benign finding in the fibroid. And this is the appearance of degenerated fibroid. You find cystic, here, this is the appearance of degenerated fibroid. Bizarre shaped geographical appearance of the cystic areas, not like the adenomyosis where we find spots, just cystic spots like this. So this is a degenerated fibroid, and usually it is hyperechoic in signal due to hyaline and myxoid degeneration. Then came the role of MRI in fibroids. MRI imaging can assist in preoperative planning for myomectomy by enabling accurate detection and localization of individual tumors. Conditions that mimic leiomyomas by physical examination and ultrasound can be characterized with MR imaging. MR imaging enables quantitative monitoring also to therapy. With leiomyoma, change in size of the individual leiomyomas as well as the uterus can be assessed with MR imaging. But the main aim, preoperative planning, and to differentiate between other conditions that mimicking leiomyomas as focal adenomyosis. This is the typical appearance of fibroids on MRI. They are typically hypointense fit T2. Typically hypointense fit T2. These are multiple variable sized hypointense lesions, well defined, not indenting the cavity. This is the normal junctional zone and the normal endometrium, and these fibroids all are not indenting the cavity. So these are usual ordinary fibroids. Here another fibroid indenting the cavity but less than 50%, well circumscribed mass of low signal intensity within the anterior uterine body that distorts the endometrial canal, and the mass has a thin rim of high signal intensity around. This is the ordinary fibroids. And then we came to the problematic cases, the leiomyoma variants and the uterine leiomyomas and their variants. We have the ordinary leiomyomas, benign, non-degenerated, degenerated, cystic, hemorrhagic, fatty, lipoleiomyoma, hyaline and myxoid degeneration. We have also the mitotically active leiomyomas like the cellular type and the atypical leiomyoma, and we have the smooth muscle tumors of uncertain malignant potential, the leiomyosarcoma, which is malignant. We have many other variants, and this is a nice paper I found that state the different appearance of the degenerated fibroids. يبقى احنا وقفنا عند الفاريانتس بتاعت اليوتراين ليومايوماز اند ذير فاريانتس. نيجي بعد كده للابيرنس بتاعهم في الام ار اي. طبعا كل بارت اوف ديجنريشن هيبقى له ديفرنت ابيرنس في الام ار اي. يعني مثلا التوتالي سيستيك ده بيبقى ايزو انتنس ريلاتيف تو ذا مايومتري. في التي 2 بيبقى فيه internal areas of high T2 signal، وبالانترافينوس كونتراست بيبقى فيه corresponding area of enhancement للحتة السوليد اللي هي present inside the solid parts inside. The hemorrhagic هلاقي فيه areas of high signal in T1. There will be areas of high signal in T1, moderate to high signal in T2, والintravenous contrast will be variable. الفاتي هيبقى فيه moderate T1 signal intensity which suppress on fat suppression، ودي مهمة اللي هي اللايبو ليومايوما. في التي 2 هيبقى of moderate signal زي بتاعت الفات العادي، والانهانسمنت هيبقى of variable enhancement. الهايلاين هيبقى ايزو intense في التي 1 وهايبو intense في التي 2 with decreased enhancement compared with the ordinary leiomyomas. الميكسويد بيبقى هايبو intense وليه كاركترستيك بقى signal ان هو بيبقى فيه high peripheral rim of T2 signal، يعني بيدينا laminated appearance on intravenous contrast. The established characteristics of the usual leiomyomas on parametric MRI Its margins are usually well defined, as the first two cases we have seen, the margins well defined. A shape, round or oval, the signal intensity on T1 homogeneously iso-intense, the signal intensity on T2 homogeneously hypo-intense to the uterus، يعني هي بتبقى hypo in T1 and hypo in T2. Enhancement on gadolinium contrast image, yes, can be variable. Enhancement indicates viability. Signal intensity on diffusion weighted images تبقى hypo-intense compared with the normal smooth muscles, and this we called the blackout phenomena. And on the ABC map, it is hypo-intense compared with the normal smooth muscles, blackout phenomena. This is the ordinary, the most characteristic being homogeneously hypo-intense. All fibrous tumors are homogeneously hypo-intense in T2. Homogeneously hypo-intense in T2. This table also shows the features of the degenerated leiomyomas and different subtypes of degenerated fibroids. In the hyaline degeneration, it is the shape in the hyaline and cystic degeneration, and in the myxoid degeneration, and in the red degeneration, usually it is rounded or oval and it is well-defined outline. But in the calcific portion, because the calcification is signal void, we can find that it is amorphous in appearance. And if you suspect that there is calcification, please do second look ultrasound to see the calcified foci. Signal intensity on T1 weighted image, it is hypo to iso intense in all of these, but in the calcification it is hypo-intense in T1 and the T2. In the myxoid type of degeneration, the fibroid may be markedly hyper-intense on T2. This is the myxoid type of degeneration. Other histological types, we have the cellular leiomyoma, and this is the cellular leiomyoma is very considerable because sometimes you cannot differentiate it from the leiomyosarcoma because it is bright signal on T2. It is rounded or oval of variable signal intensity on T1, diffusely hyperintense in T2. In T2 it is diffusely hyperintense, and the problem also that it shows restricted diffusion like the leiomyosarcoma. Then we have the lipoleiomyoma. It is well defined, rounded or oval, heterogeneous because of various amounts of different types of tissues. So it is heterogeneous in appearance, and mainly it is suppressed on fat suppression. The very important that it is suppressed on fat suppression. الrestriction بتاعها unknown. We didn't know it is restricted or not because it contains fat and different components, so it can be restricted sometimes. And it causes marked enhancement on contrast. The lipoleiomyoma and cellular leiomyoma both show marked contrast enhancement. Then we have the stump, which is the smooth muscle tumor of uncertain malignant potential. It is heterogeneously hyperintense in T1, and it shows heterogeneous hyperintense area on T2. A contrast enhancement is variable, or restriction also unknown. We can see the different types of degeneration of the fibroids, how it appear on MRI. This is the hyaline degeneration. It is the commonest type of degeneration. Fibroids with hyaline or calcific degeneration are difficult to distinguish from the non-degenerated fibroid on MRI. Areas of calcification can appear as signal void on MRI. The calcified area will appear as signal void. Here we have an area of hyaline fibroid showing hyaline degeneration with the peripheral hyperintense rim. And then we have other smaller fibroids, interstitial indentation, but they are signal void mostly because they are calcified fibroids. And they are not indenting the cavity. Here they are not indenting the cavity. This is another type of fibroid. This is the cystic degeneration. Note it is very low on T1 and bright on T2 like any cyst. And it is seen in 4% of fibroids and typically occur after hyaline degeneration. Here is the myxoid degeneration. Sometimes the myxoid degeneration can be difficult to differentiate from leiomyosarcoma, but still it is well defined and contain areas in the middle, cystic areas of degeneration in the middle. So the appearance of myxoid degeneration in a fibroid is important to differentiate from leiomyosarcoma. Here is also the red degeneration secondary to hemorrhagic infarction due to obstructed draining veins. The patient may present with acute abdomen and occur mostly in the pregnant females. The fibroid may have a peripheral rim of low signal on T2 image and high signal on T1 image due to peripheral obstructed veins. Here is the lipoleiomyoma, bright signal. If one can see it, we can say that it may be a dermoid, but it is in the wall of the uterus, so it is a lipoleiomyoma, echogenic, well-defined lobulated tumor, typically intramural in location and mostly suppressed on fat suppression. This is another case. Here is a lipoleiomyoma. Here is the small lipoleiomyoma seen here, suppressed on fat suppression and bright on T1. This is the bright signal on T1 and suppressed on fat suppression. This is another case of lipoleiomyoma showing heterogeneous signal. This is the CT appearance of it. Here the CT appearance show multiple hypodense spots of fat inside. And here also by MRI show bright signal on T1 which is suppressed on fat suppression. So this is a case of pedunculated lipoleiomyoma. What about this case? She's a female 35 years coming with abdominal enlargement and no other symptoms. She has no bleeding, just abdominal enlargement. What could be the differential diagnosis of this case? Markedly enlarged uterus, heterogeneous myometrium, and when we put Doppler here, here there is marked vascularity, not marked vascularity, multiple well-defined lesions present in this myometrium and showing perifibroid plexus, small fibroids replacing most of the myometrium. When we found this is one of the variants of leiomyoma, here also, this is a panoramic view showing the enlarged uterus, and there is also a subserous fibroid seen, but have the same appearance of the rest of the uterus. You have to detect the endometrium. Here the endometrium is 10.4 millimeter, but it is not indented by this myometer, and so the patient has no bleeding. And this is the MRI appearance. We have multiple leiomyomata, multiple innumerable leiomyomata, and this is the pathological picture from the literature. So this is leiomyomatosis, uterine leiomyomatosis. Then how to differentiate between uterine leiomyomas and leiomyosarcoma? A leiomyoma and leiomyosarcoma are both at opposite end of the pathological spectrum of the uterine smooth muscle tumors. Much remain to be learned clinically, particularly regarding the histological entities, which is called the leiomyoma variants that we have just said. On MRI, moderate T2 signal is the only finding that may suggest one of the variants, although ordinary leiomyomas may cause homogeneous moderate T2 signal. But when the mass is ill-defined margin with areas of hemorrhage and necrosis and marked heterogeneous enhancement, then we should think of leiomyosarcoma should be suspected in these cases. This is how to differentiate between, this is the leiomyosarcoma characteristics on MRI. Regarding the margins, it is ill-defined infiltrating, as in this case, ill-defined infiltrating margins. The shape is irregular. It is irregular in shape. In some cases, it is irregular in shape, but here in this picture, it appears ill-defined, infiltrating, and often solitary. Leiomyoma, the ordinary leiomyomas, usually they are multiple, and the leiomyosarcoma, usually it is solitary mass. The signal intensity on T1, heterogeneous hyperintense, resulting from areas of hemorrhage and necrosis. And in T2, it is heterogeneously hyperintense, also resulting from areas of cystic necrosis. And there is heterogeneous enhancement on post-gadolinium, as in this case, heterogeneous enhancement on post-gadolinium scan. In diffusion weighted image, it shows restricted diffusion, bright in the diffusion, وhypointense في ADC map. This is two pictures showing the difference between leiomyoma and leiomyosarcoma here. This is the leiomyoma and this is the leiomyosarcoma. This is homogeneously hypointense and this heterogeneously hyperintense on T2. Both leiomyosarcomas and the benign cellular leiomyoma display restricted diffusion, and from this came the pitfalls. Sometimes it is a cellular leiomyoma and not leiomyosarcoma, but since there is some suspicion, you should put the possibility that it may be leiomyosarcoma together with the correlation with the clinical state of the patient. Is this the leiomyoma rapidly enlarging or not? We have to know the history of this female. And here is the cellular leiomyoma, bright on T2. Leiomyosarcoma, heterogeneous with high signal on T1 and heterogeneous signal in T2 with the solid component being bright, as you see here. And then it is heterogeneous intense enhancement in the post-contrast study. The role of diffusion imaging in differentiating leiomyoma from leiomyosarcoma showed overlap in the ADC value between leiomyosarcomas and the ordinary leiomyomas should be resolved with the evaluation of tumor myometrium contrast ratio on T2. The signal intensity of the tumor on T2 was classified as the tumor myometrial contrast ratio by using the following formula. نحن نقدر نقيس the signal intensity of the tumor on T2 and differentiate it between the normal myometrium. This is a study done. I didn't try cases like that, but it is one of the studies done on the differentiation between leiomyosarcoma and leiomyoma. Also the ADC value. Here the ADC value for sarcomas is 0.86, lower than the leiomyoma, which is 1.1. So there is lower value of ADC with the leiomyosarcoma group. And this is the bridging vascular sign, which is very important in the pedunculated subserous leiomyomas to know that it is related to the uterus or it is adnexal non-uterine lesion or broad ligament fibroid, for example. So the bridging vascular sign is an important sign to see that this pedunculated mass is related to the uterus. And then came the how to comment on the uterine leiomyoma template report. The uterus, we have to say the orientation of the uterus, the size. When you find large size, and usually myomas show large sized uterus, you have to state first in your report that the uterus is enlarged. And then the endometrial thickness, the junctional zone thickness. Regarding the leiomyoma, we have to comment on the size and volume of the leiomyoma, the location of the leiomyoma according to the FIGO classification, the size of the stalk if it is pedunculated, regarding the length and the thickness of the stalk, signs and types of degeneration, enhancement characteristics, and differential diagnosis. In the presence of atypical mass, you should think of leiomyosarcoma, features suspicious of sarcoma, like heterogeneous signal on T2 and the dark T2 areas, nodular borders, and signal flow void areas, intralesional hemorrhage, and intralesional necrosis. This is very important. Or to find a mass of undetermined origin, is it ovarian or uterine? If it is ovarian, we have the typical ovarian peak sign. If it is uterine, you have the claw sign that the uterine tissue is seen wrapping around the solid mass, and the bridging vascular sign to confirm that it is uterine lesion. And then we have the differential diagnosis with the fibroid, which is the adenomyoma. The adenomyoma is iso-intense mass to the surrounding myometrium, but it has ill-defined border, and we will state the appearance in the second part of the lecture. يبقى فيها foci, small foci of high T1 and T2 signal, no pseudocapsule, and little mass effect. This is the adenomyoma. Regarding if the patient will do a uterine embolization, we have to know the size, location, and the enhancement, uterine and ovarian masses. Thank you. and we will complete the second part of the lecture inshallah. نعم